Very good evening to all of you. So today we are here again for our next part of the Organon. Today we will start with the aphorism 83. So from here on the case taking starts. Dr. Hahnemann, he gives different points on how to take a case. There are around 22 to 25 aphorisms of case taking. Today we will try to do at least 10 case taking aphorisms. So wherever there is something important, we will stop there, discuss it, because when we are doing a case, these are the points, it is kind of a recipe which is given to us, the pointers to the recipe for making something. So these are those pointers. This is a kind of formula, how to do the thing. But again, like I have told before also, that case taking is basically an art. From science to art we have to go. This is the science of case taking which we are going to study today, which we have to change into the art. You give this formula to everyone, you give the formula to recipe to everyone, to many chefs, but they will not, whenever they make something out of that recipe, the dish will not be same of all the people. That is the art. Application of science is basically art. So we will try to understand the science today, and then by practice, by knowing about it more, by doing it again and again and again and again, by refining it, we will transform it to a thing which we call as the art of case taking. So we'll go ahead, we'll start with it. So aphorism 83. This individualizing examination of a case of disease. Okay. Individualizing. We have to do an examination of the case which will individualize the whole case. That is the aim of the case taking. Yesterday I was talking with some students in my clinic that, like, after 2 months, 3 months, 4 months, when you are doing case taking on a regular basis, if you are observing, because we have to observe ourselves from time to time, if you are observing that you are taking the case in the same way, you are asking the same questions again and again, you are getting the same kind of answers again and again in your case, then somewhere, we have stopped in our progression, we have stopped in our development. That means that we are not individualizing the case now. We have remembered or memorized some questions, and we are asking those questions again and again and again and again. And when you're asking the same question again and again, most of the time you will get the same answers, the similar answers. You will end up with in the similar remedies, similar group of remedies. So every 2-3 months, we as homeopaths have to somewhere, sit, meditate in the sense, try to understand about ourselves, that whether we are developing continuously or we have stopped somewhere. Because the purpose of taking a case is to individualize the patient as a whole. So that has to be done. That should be done every time we take a case, for which I shall only give in this place general directions. So there will be general directions by which will Dr. Hahnemann has given from aphorism 83 onwards regarding the examination of the case, of which the practitioner will bear in mind only what is applicable for each individual case. Again, the same thing, that the practitioner has to bear in the mind. He has to keep this thing, this thought, this idea alive in his mind, that every case is an individual case, and whatever is applicable of these directions, I will apply only those things in this particular case. Demands of the physician. What is demanded is to take a case. What is the requirement? Nothing but freedom from prejudice and sound senses. Only two things. You should be away from prejudice. Don't take a new case, as you have taken the some old case, don't bear in the mind any kind of remedy, any kind of particular symptom when you are taking the case. Okay. We should be away from prejudice. And sound senses. The senses should be sound. Sound senses here means that it is not that your hearing should be very sharp or smell should be, you should be attentive. When you are taking case, we have to be very attentive. The next line, attention in observing. Very attentive. We have to be there. We have to forget everything else and we have to be there. We have to be present there. And fidelity. Fidelity means loyalty. Fidelity in tracing the picture of the disease. We have to be very truthful that whatever the patient has told or whatever has been observed, it should be taken as it is. Many times I have seen the doctors who have this tendency, on working the rubrics of delusions. If you have this thing, then this kind of delusion may be there, or this thing. That is completely against this part, the fidelity in tracing the picture of the disease. There is this doctor, the lady, she had, he was taking a case. Someone told me, I have not heard personally, but someone told me this thing, that he was taking the case and the lady, the mother of 3 children, she told that I have 3 children. So he took the rubric delusion ruined she is, that, oh, she has 3 children, she might be thinking. So this might be, this speculation is basically an infidelity. This is falseness. Whenever we start speculating and that speculation comes in our analysis and then it goes into our remedy, tracing the remedy, the whole thing goes away. So it took this rubric delusion ruined and he gave some medicine to the patient. And for the observer, if there is some student, he's there will be a wow that how he got to the remedy. We have to understand that we are not here for that wow effect. When we go through the Organon, there are very small things in the Organon, which basically tells us that how we have to understand the patient, how we have to understand the materia medica, how we have to understand the homeopathy. Homeopathy is all about truthfulness. The more truthful we are in our approach, how we have to approach the case, how we have to approach the patient, how we have to the things which we know in our experience, the more good results come out of it. So there are 4 things which Dr. Hahnemann is asking to us. Well, we start with our case taking: freedom from prejudice, sound senses, attentive observation, complete attention, and fidelity, truthfulness, while we are tracing the picture of the disease. So aphorism 84, the patient details the history of his sufferings. So the patient will tell about the history of the sufferings, all the details which are there. Those about him tell what they heard him complain of, how he has behaved, and what they have noticed in him. The attendants, the family members, the friends, the people around the patient, they will tell us about how the patient complains, how he has behaved during the disease. And the physician sees, hears, and remarks by his other senses what there is of an altered or unusual character about him. And the physician, he observes the patient, anything unusual about him, what he sees, what he hears, anything. So basically there are 3 sources of our information. One is the patient himself. Second are the attendants around him. And third is the physician himself. What physician notes? Because what the physician notes, even the patient does not know that he has this thing. Even the attendants being with him from a long time, they might overlook that thing. But physician, because of his knowledge of materia medica, because of his practice, because he has been doing this from a long time, he can make out of the characteristics in the patient, in the details of the history. So these are the three sources, and they should be used properly whenever we are taking the case. He writes down accurately all that the patient and his friends have told him in the very expressions used by them. Whatever the expressions, I always encourage that, whatever the language the patient is using, write down in the same language, so that you can remember next time what kind of expressions, what kind of words they used. While we are taking a case, on the side you make a small box of observation, write down the observation, that how they express the things, how they were telling about the things, what were the expressions, how was the pitch of the voice, because all these things, maybe next time you, maybe because if you have so many patients, maybe next time you will not be able to remember those things, or not very clearly. So write down as much as we can, it is best. Keeping silence himself, he allows them to say all they have to say. Now this is very important for me. I have always I personally always focus on this thing, keeping silence. Now usually the keeping silence is more here, but it should be here also, in the mind. Try that whenever your concentration is on the patient, try to keep your mind as silent as it can. A silent mind is able to hear more, to analyze more, to absorb more. Here we have to keep silent, that is understood. Okay. But here also, a very silent mind, let those words fall on the mind, because if the mind is constantly speaking, or mind is into some kind of conversation, the thought is somewhere, and we will not be able to get the whole information. So the silence part is very important. And refrains from interrupting them unless they went wrong. Don't interrupt them at all, let them speak. Okay, even the, don't let the attendants interrupt the patient, or the patient interrupt the attendant. That is also important, because many times, patient is speaking and the attendants, they interrupt. Not, if this kind of thing is happening a lot, then tell the attendant to sit outside for some time and talk with the patient. Then tell the patient to sit outside the cabin and talk with the attendant. Okay, there was this couple who came, the female, she came for the case taking, husband and wife. So the female was a patient. So whenever the female was telling, the husband will, keep giving him the information, and the patient will deny that information. It came to that point that they started fighting in the clinic. So we have to avoid that kind of thing to happen, from happening. Okay, so tell them to be silent, or if they cannot, then just tell them to wait outside for some time. So, and refrains from interrupting them unless they went wrong. If they wander off to some other kind of subject, to other matters, they are talking something which is, then, very slowly we bring them to the topic with few words as we can. It is very important while taking the case that the physician uses as few words as he can, until and unless it is necessary. The physician advises them at the beginning of the examination to speak slowly. Tell them to speak slowly, that I have to write it down, because there will be many important points which you have to write it down. So, it should not be like if you are writing the previous point and we miss on the next part. So tell them to speak slowly. Okay. Or if you can, tell someone, if you can, someone with you, some assistant, tell them to write down whatever they are saying, and you also write down the important points, so that you can have as much of information as you can. So in order that he may take down in writing the important parts of what the speakers say. Footnote to Aphorism 84. Every interruption breaks the train of thought of the narrators. Why we have to refrain from speaking while the patient is narrating? Because whenever the patient is narrating something, there is a train of thoughts. There is a flow of information which is going on. And with that information is what we are going to get some symptoms on what has happened or how it has happened. And if we break that train of thought, the patient or the attendant or whoever is telling us, they might not be able to go back there. All they would have said at first does not again occur to them in precisely the same manner after that. So once that train of thought is broken down, if that narration is broken down, then there is very less chances that they can tell it in the same precise manner. So he begins a fresh line with every new circumstance mentioned by the patient or his friends, so that the symptoms shall be all ranged separately one below the other. He can thus add to anyone that may at first have been related to in too vague a manner, but subsequently more explicitly explained. So everything which we are writing, every symptom, it has to be started with a new line. It should not be jumbled up, so that when we are going through, it again, we don't miss some points because they are jumbled up. We can do many kind of new things with this process. You can put in the boxes, you can underline the important parts. But yes, many times when we are doing this thing, that highlighting some point or underlining, like I was talking about this in this time, the Thailand workshop. Many times when we think about some symptoms to be characteristic, for example, I think 2 or 3 symptoms should be characteristic. From there, I prescribed lycopodium, but the patient didn't got better with lycopodium. So the next time when the patient comes, I will again think from all those 3 or 4 points which I thought of characteristic. I will try some other remedy. I will give pulsatilla, I will give calcarea, I will give sulfur, which has those kind of 3 or 4 symptoms. I might go, give ignitia or something like, because then I will not think out of those 3 or 4 symptoms. I will be prejudiced with those 3 or 4 symptoms. So we can mark it down, but we have to keep in mind that this marking can also make us prejudice. Every time we see the case again, if we have to see it again, if we have to analyze it again, then we will go with all those 3 or 4 symptoms and we will keep arriving at almost similar remedies. So the best way, if you can reanalyze that, okay, I am getting prejudiced now, I am prescribing only on those 4 or 5 symptoms or 3 or 4 symptoms which I am prescribing from long time. Just throw those symptoms out of your analysis. Make it a mind that I am not going to take these symptoms now. I will not be prejudiced. I will read the whole case again. If needed, I will ask the patient again. Take some other symptoms, take some other characteristic symptoms, go through the whole case taking again and try to find out some other things from the case. And from there, I will prescribe. And this helps you to get out of that prejudice. Okay. So here in the aphorism, Dr. Henneman is saying that every symptom should be started with a fresh line, so that when we are asking about these symptoms, if we get some more information about it, some extra information about it, we can write it down. Okay, so always give some space with the symptoms. When the narrators have finished what they would say of their own accord, the physician then reverts to each particular symptom and elicits more precise information respecting it in the following manner. So when the narrators have finished, they have done, they have told whatever they have to tell on their own accord. The physician then asks about each particular symptom. He will start from the beginning. For example, the patient has told about the headache, then that I have headache, it is very severe, it is violent, the vomitings come with it, There's sometimes vertigo also, I have to take a painkiller. Then when all these things are said and everything is said, then the physician will start with, okay, tell me about something more about the headache, some aggravating factors, some ameliorating factors, what kind of pain it is, how it extends, so more precise information. He reads over the symptoms as they were related to him one by one. He will read over the symptoms as they were told to him, and about each of them he inquires for further particulars. For example, at what period did this symptom occur? So, was it previous to taking the medicine he had hitherto been using, while taking the medicine, or only some days after leaving of the medicine? So, we will start asking some further particulars, some further questions. Like I was telling that what time the pain starts, or the pain has been there before you started some kind of medication, or it is only during the medication or after leaving the medication, what kind of pain it is, what sensation exactly. Try to ask the patient that what kind. Many times the patients use some words in their language, whatever the language they use. In that language, they use some things, which we have to relate to what kind of expression is given in the materia medica of that language. Some may use that it is bursting, or it is pulsating, or it is very dull pain. I cannot even make that where it is, but it is there always. Where was the precise spot? Did the pain occur in fits by itself at various times? Was like the pain was in episodes, or it was a continued pain without intermission? How long did it last? At what time of the day or night? In what position of the body was it? Worst or ceased entirely? So some time aggravation, some time modalities, some position modalities. These are the questions which we can ask. What was the exact nature of this or that event or circumstance mentioned? So whatever basically they are mentioning, we have to elicit more information regarding it. When did this happen? How did this happen? What was the reaction? You know, how it started, how it ended, everything described in plain words. Just tell the patient to describe as you think about it. Aphorism 87. And thus the physician obtains more precise information respecting each particular detail, but without ever framing his question so as to suggest the answer to the patient. So we have to ask the question, but we have to frame a question that the question does not suggest an answer. First of all, don't give options. If you're asking what kind of pain it is it bursting, or it is irritating, or it is like a piercing, don't give them the options until and unless it is required. Just first ask them in simple question that what kind of pain it is, what kind of food you like, any food causing any problems. Just the question has to be in a broad way. We have to see, mostly when patient comes to a homeopath, he is coming from the other system, coming to homeopathy for the first time, or he might be exposed to some other homeopaths, but he is coming to you for the first time. So we have to make him think about the things. Okay, we have to give him some questions so he thinks about it. We should not be giving him answers, that will be a more of misleading the way to the patient. We will be misleading them to give some kind of answer which are not truthful. For example, I asked that, do you like cold water? So this is a more of a yes or no answer. Dr. Kent has very particularly told about this thing in his philosophy on this case taking part, that if the answer to your question is yes or no, your question is wrong. It is the wrong question. The question should not have been formed in a way, in this way. Do you get angry easily? This is a yes or no answer. No. What kind of nature you have, like how you behave, how is your disposition? We have to ask broader questions so that he shall only have to answer yes or no. We should not frame the question in a way that it is a yes or no answer, else he will be misled to answer in the affirmative or negative, something untrue, half true, or not strictly correct, either from indolence or in order to please his interrogator. Okay? So out of the indolence means because it has to be yes or no. So he is not giving in the other facts. He's not putting in the other facts to answer that question. Do you like cold water? Yes, I like cold water. Okay. So that will be more of half true or not strictly correct. We cannot rely on that kind of information, from which a false picture of disease and an unsuitable mode of treatment must result. So we will be forming a false picture of the disease, and because the picture of the disease is false, the information which we have got is not correct. So we will not be able to give a correct medicine. So in these aphorisms, these are basically kind of do's and don'ts. So we have to remember the don'ts also. What we do, that we will remember because we are doing it. But what we don't have to do, that also we have to remember very. We have to keep that thing in the mind. For instance, the physician should not ask, was not this or that circumstance present? Regarding the circumstances, whether was it a hot day? This is a yes or no answer. Okay, what kind of a day it was is a more better answer. Question, sorry. He should never be guilty of making such suggestions, which tend to seduce the patient into giving a false answer and a false account of his symptoms. So, this is why it is an art, the case taking, because we have to, the case taking, the interrogation is an art where we have to make the patient think about everything, about his feelings, about his sensations, about his symptoms. Many times the patient have forgotten so many things about their life, about their disease also. So we have to make them aware of all those things. We have to bring back all those memories to them. So our question should be in a way that all those things come to the patient. We have to stimulate it in a right way. If in these voluntary details nothing has been mentioned respecting several parts or functions of the body or his mental state, the physician asks what more can be told in regard to these parts and these functions or the state of his disposition or mind. Okay. So, for example, while giving the case, when the patient is narrating it, if some details are not given regarding some parts of the body, regarding some the mind or the other functions of the body, then the question will, the physician will start asking questions regarding those particular things. But in doing this, he only makes use of a general expression. But again, we have to make use of general expressions. For example, patient is not told about the some gastric symptoms, so we just ask in general way that any kind of gastric disturbances. Let him think. Okay, how about the stools? How is your thirst? How is sleep? How is your memory? So we just ask in a general way in order that his informants may be obliged to enter into special details concerning them. Okay. So even the information from the informants can come when we start asking in this way. For example, if I that how is the memory? Before the patient tell, the attendants will tell that the memory is very sharp. His memory is very sharp, or it is not very good. He forgets the things easily. We have to make him remember of about the events or about something which has happened in the past. For example, the examples for what uh, was just told, like how the we have to ask about, in a general way, what is the character of his stools, how does he pass his water, mean urine, how is it with his day and night sleep, how is the sleep in the night, how is the sleep in the day, what is the state of his disposition, his humor, his memory, like I was telling, how about the thirst, what sort of taste has he in his mouth, what kinds of food and drink are most relished, what are most repugnant to him, has each its full natural taste, like for example, whenever you are eating something, do you get it full taste or it is some kind of unusual taste, how does he feel after eating or drinking. So these are basically general questions. Has he anything to tell about the head, the limbs, or the abdomen? Okay. So don't ask that. Do you have headaches? No. Ask him about the head. Do you have pain in the limbs? No. Ask him about the limbs. If there is something important, it will come to his memory. Okay. If there is nothing there, nothing important there, nothing which bothers him much, or there is nothing, then he will just simply say that no, there is no problem with that thing. Aphorism 89. When the patient, for it is on him we have to, the, we have, yes, for it is on him we have to chiefly rely for a description of his sensations, except in the case of faint diseases. So, okay, see, the subjective symptoms, there are symptoms which are subjective, which belong to the patient, which only patient can tell. For example, the sensations, for example, what he is feeling, that cannot be told by the attendant, that cannot be observed by the physician also, because it is something which is internal. Sensations, what kind of pain is, what kind of sensation he is feeling or she is feeling. So we have to depend on patient for these informations. Behavior can be told by the attendant, some kind of talk which the patient keeps on talking, that can be told by the attendants. But for the subjective symptoms, what the patient is feeling, those sensations, those pains, that all thing, some extensions of the pain, only the patient can tell all these things, except in the case of faint diseases. Faint disease, for example, there are some kind of delusion, there is some kind of symptoms which are made up. We cannot rely on those, in those cases, on the patient. When the patient has, by these details given of his own accord in the answer to inquiries furnished, the requisite information and traced a tolerably perfect picture of the disease, the physician is at liberty and obliged, if he feels he has not yet gained all the information he needs, to ask more precise, more special questions. When the patient has given all the details which he can, and somewhat picture of the disease is traced, but the physician feels that no, I need something more. I need something, more regarding this thing. There has to be more information. Then at that time, the physician is at liberty and also obliged to ask more precise questions, to ask more special questions. But then again, those special questions should not be yes or no questions. That has to be kept in mind. Okay, there are a few examples in the footnote. For example, how often are his bowels moved? For example, okay, from the first question would be how are bowels, how are stools. If the patient is not giving proper, then how we can start asking more about it, that how often are his bowels moved, what is the exact character of the stools, did the whitish evacuation consist of mucus or feces, some examples, mucus or feces or something, we are giving the examples now. Had he or had he not pains during the evacuation, what was their exact character, where were they seated, the pains, what did the patient vomit, is the bad taste in the mouth putrid or bitter or sour or what? Okay. So now we are giving a little options to him, because many times the patient is not able to understand also that what kind of information we are asking. So we have to give some examples. But it is in the third phase, third phase of the case taking. At what period of the day was it worst? So we have the main thing to understand that we do not start with these kind of questions. The first phase is where the patient is voluntarily telling us everything. The second phase is when we feel that okay, he has told everything, but we need more information about it. So general questions are asked. So this is the third phase when we think that still the information is not given properly, and we need to give him some options or some things we have to tell him that. Then we start questions like this. So this taste of the mouth before or after eating or during the repast, at what period of the day was it worst? What is the time of the day when it is worst? Whether it is in morning, whether it is afternoon, whether it is evening, we can ask like that. What is the taste of what is rectated? Whatever is rectated or whatever is, what is the taste of it? Does the urine only become turbid on standing, or is it turbid when first discharged? The color of the urine, what is its color when first emitted, or what color is the sediment, or how does he behave during the sleep? Does he whine, moan, talk, or cry out in his sleep? So the main thing is to understand that then now we have started asking more uh, precise questions. From general we are coming to more smaller parts to more precise parts, giving options, more smaller things in a big thing. We are trying to understand that thing. Does he start during sleep? Does he startle or he snores during inspiration or during expiration? Does he lie only on his back or on which side? What is the position during the sleep? Does he cover himself well up or can he not bear the clothes on him? Does he easily awake or does he sleep too soundly? The character of the sleep, how it is. So we have to give the options. And these options, now we have to understand one more thing, because I think when we will be done with the case taking from the Organon, I would like to discuss few points of case taking apart from this thing. Apart from this thing, because I think though they are also very important. It is basically based on this thing. Whatever Dr. Hahnemann has told, it is based on this thing. What it is, more of the things coming from the practical experience, that what are the things which should be done and which should not, which should be avoided. So the main thing is that all these questions, the more deeper questions, the more precise questions, how they come into our mind is when we keep reading Materia Medica. Because when we have read about positions in Materia Medica, then only the question of asking about the position will come. At what kind of position he sleeps in, or what kind of character of the sleep, because we have read about the different characters of the sleep. So Dr. Kent also describes it that the Materia Medica will become your language of case taking. So it has to flow from there. So again, coming to the first thing which we were discussing, that if somewhere we think that our case taking has become more repetitive, that also means that our study of Materia Medica has become less. Because if we are continuously going on with our study of Materia Medica, we are studying new and new remedies, we are studying new and new symptoms. Those symptoms will automatically keep coming in our mind when we are taking the case. They will automatically come. How does he feel immediately after waking from sleep? So when he wakes up from the sleep, how is he feeling? Is he feeling fresh? Is he feeling sleepy? If sleepy or some symptom is there, some headache is there, how often does this or that symptom occur? What is the cause that produces it each time it occurs? If there is some symptom coming, what is the cause? How it starts? Does it come on while lying or sitting or standing or when in motion, only when fasting or in the morning? Uh, I think yesterday we had a patient. the girl around 13 years old, she told that, she feels this intolerable hunger. So the next question is that every time you're hungry or some particular time? So you know, when I wake up in the morning, when I wake up, the first thing which I have to do is eat something. I have to do that thing. Otherwise, there is a very bad sensation, and there is very intolerable hunger which I feel. I cannot tolerate that. But it is not during the whole day. So that becomes a characteristic of the case. That becomes something which you can prescribe upon. So only when fasting, or in the morning, or only in the evening, or only after a meal, or when does it usually appear? When did the rigor come on? Like for example, in the fever, when does the rigor or chill comes on? Was it merely a chilly sensation, or was he actually cold at the same time? It was only a sensation of chill, or he was also cold to touch? If so, in what parts? Or while feeling chilly, was he actually warm to touch? Or it was opposite, that he was feeling chilly, but when someone touched him, it felt more warm or more hot. Was it merely a sensation of cold without shivering? Was he hot without redness of the face? What parts of him were hot to the touch? Or did he complain of heat without being hot to the touch? Like there is this patient that whenever the fever come, only the abdomen becomes hot. How long did the chilliness last? How long the hot stage? When did the thirst come on? During the cold stage, during the heat, or previous to it, or subsequently to it? So there are so many questions, but these all questions are coming from Materia Medica. They belong to some remedies. When you have read about the thirst of different remedies, then there can be so many questions which will come, whether the thirst is quenchable or unquenchable. What kind of water do you want at that time? Does that water ameliorates the thirst or no? So many questions. How great was the thirst, and what was the beverage desired? When did the sweat come on? At the beginning or at the end of the heat, or how many hours after the heat? Because in some remedies, it is not immediately after the heat, but the heat has to go on for many hours, and then the sweat comes. When asleep or when awake? How great was the sweat? Was it warm or cold, or on what parts? How did it smell? What does he complain of before or during the cold stage? What does he complain about? Like whenever he's getting chilly, whenever the cold stage is there, what are the other symptoms which are coming? Because it is very important in the intermittent fevers. When we will go to the part of intermittent fevers, we will talk about this thing. What during the hot stage? What after it? What during or after the sweating stage, etc. So there are so many questions which we can ask to get the precise character of the symptoms. So when the physician has finished writing down these particulars, he then makes a note of what he himself observes in the patient, the most important part of the case taking, and ascertains how much of that was peculiar to the patient in his healthy state. Again, the examples of that thing. For example, how the patient behaved during the visit. Whether he was morose, quarrelsome, hasty, lachrymose, anxious, despairing, or sad. We talked about this in last workshop in Thailand. The observation part. We have to observe. But before observing, we have to understand how a morose person will react, you know, how a quarrelsome person will react. Like I told you about that, the couple. So the first thing which we noticed about the lady was that she was quarrelsome, or sad, or hopeful, or calm, etc. Whether he was in a drowsy state or in any way dull of comprehension. How was the intellect? Was he able to understand the things? Like yesterday we saw this patient of cancer from Brazil. So whenever we were asking him some question, he would take some time before answering. There will be a pause of 4 or 5 seconds before he started answering. But then the answer will be a smooth one. So that means he has to think for some time before answering the question. So we cannot give him a remedy which have quick minds. He's not a person who is having a very quick mind. He may be somewhat confused about the answer. He may be somewhat, he want to be very sure about the answer, that whatever the answer I am going to give, it is the right answer. Whether he spoke hoarsely or in a low tone or incoherently or how otherwise did he talk. There's a patient who comes. So when he's speaking, he's like, I have to tell him that, can you please speak loudly? Oh, so okay, he can go up to that. Okay, doctor, I can tell you. Then I have to go more, kind of across the table to hear what he wants to say. And some, they're so loud. Then there is one patient who, I am in my cabin in my clinic, and he is outside in the street, and I can hear him talking, like on the phone, or he's talking to someone. He's asking about something. He's so loud. So these are the characteristics which we have to observe. The patient or the attendants, they don't tell about these things. What was the color of his face and eyes and of his skin generally? What degree of liveliness and power was there in his expression and eyes? What was the state of his tongue? His breathing, the, the smell from his mouth, and his hearing. Were his pupils dilated or contracted? How rapidly and to what extent did they alter in the dark, in the light? So these are some things which we can examine. What was the character of the pulse? What was the condition of the abdomen? How moist or hot? How cold or dry to the touch was the skin of this or that part, or generally? Whether he lay with head thrown back, with mouth half open and wholly open, like in the acute cases we can see for these things, or in some unconscious cases with stupor, cases with delirium. These kind of symptoms are very helpful at that time. In fevers, with the arms placed above the head of his back, or in what other position? The position in which they sit, like we were talking in the workshop also. Some people, they are sliding down in the chair like this, completely. Some, they sit very erect. So what kind of position they are sitting, what kind of uh, you know the position they are comfortable in. What effort did he make to raise himself while he's raising himself from the chair? Like they recently we had a lady who had this, pain in the knees. There is osteoarthritis of the knees, and she said it is very painful that I can. But when she got up from the chair, she was so quick, and very rapidly she walked back. This does not tell us that, that the patient is not having pain. No, they are having pain. If they are complaining, it means then they will be having that pain. But this tells us about the character of the patient, that the patient is a very quick person, energetic, even with this kind of disease. She was around, I think, 70 years old lady. At that age, with that kind of disease, she is an energetic person. So we have to give her that kind of remedy. And anything else in him that may strike the physician as being remarkable. So whatever we think is remarkable, we have seen hundreds of patients who have pain in the knees, and the way they get up slowly. The more the pain, the more slowly they will get up. The more the swelling, they will get up more slowly. They will stand for some time. They will get into the position of walking, and then they will start walking. But this was something which was remarkable, which was characteristic, which is a very rare thing which we will see with the patients of osteoarthritis. The way she rose herself up. Okay? So the observation means, that our eyes, our ears, our nose, all our senses, they should be open to take in some information which is characteristic, which is remarkable, which is unusual. So that is the purpose of the observation of the physician. the careful observation, the attentive observation. Aphorism 91. So the symptoms and feelings of the patient during a previous course of medicine do not furnish the pure picture of the disease. So if the patient is having some symptoms and feelings which were during some course of medicine, or even when the patient is coming to us with the medicine they are taking, there are some symptoms and feelings which have started after this medication. These symptoms, they basically do not furnish, they do not give the pure picture of the disease. But on the other hand, those symptoms and ailments which he suffered from before the use of medicines or after they had been discontinued for the several days give the fundamental idea of the original form of the disease, and these especially the physician must take note of. But the symptoms which were there before they started taking the medicine, or when they have stopped the medicine, discontinued the medicine for several days, and then some symptoms come, they give us the original nature of the disease. But now today some medicines are there which cannot be stopped. We cannot stop them. So we have to ask the patient, what are the symptoms which started after the treatment started, and what were the symptoms before it. That can help us to give an idea about the original symptoms of the disease. Okay, because we cannot stop certain medicines nowadays. Like for example, if someone is having this Parkinson, they are taking Syndopa, we cannot suddenly stop Syndopa. The patient will be so much aggravated. So we have to ask that what are the symptoms which are previous to the disease, which were before the disease started. When the disease is of a chronic character and the patient has been taking medicine up to the time he is seen, the physician may, with advantage, leave him some days quiet without medicine, or in the meantime administer something of an unmedicinal nature and defer to a subsequent period the more precise scrutiny of the morbid symptom. If this can be done with some diseases, for example, thyroid or something like this, if this can be done, it should be done. The physician should tell the patient to leave some kind of medications for some days. If it can be done, again I'm saying, okay, or give them something unmedicinal, some placebo for, okay, I'm giving you this for thyroid, so don't take that, and let the symptoms come so that we can have a pure picture of the symptoms. But it should be done very cautiously and very in a way that the patient does not have much problem. In order to be able to grasp in their purity the permanent uncontaminated symptoms of the old affection to form a faithful picture of the disease. But if it be a disease of a rapid course, now if the disease is of a very rapid course, and if its serious character admit of no delay, that it is very rapid and it is very serious disease, the physician must content himself with observing the morbid condition, altered though it may be by medicines, if he cannot ascertain what symptoms are present before the employ of medicines. So in those cases, even the other medicines are going on, there are effect of the other medicine, there are some symptoms of the other medicines. The physician has to satisfy himself, content himself, or be okay with it, that okay, whatever the medicine, whatever the symptoms are there, I will employ the medicines according to them, in order that he may at least form a just apprehension of the complete picture of the disease in its actual condition. So we have to apprehend the complete picture of the disease, that is to say of the conjoint malady formed by the medicinal and original diseases. Okay? So we have to see the disease as a whole. All the symptoms produced by the medicines, there are some characteristics or some characteristics of the original disease. We have to take them whole in those cases, which from the use of inappropriate drugs is generally more serious and dangerous than was the original disease, and hence demands prompt and efficient aid. So the original disease was not as dangerous, but it was made dangerous by these drugs. So we have to take the whole picture in those cases, even the symptoms which started after taking the medicine, because when the disease is of rapid character, There is no time to ascertain or to ask what are the symptoms before. Even the patient might not be in that kind of condition to tell. So in those cases, we have to take whatever the characteristics, whether it belongs to the, because many times it is very difficult to understand in these cases whether this characteristic is of medicine or whether this, for example, recently we saw this patient of ALS in Thailand. The lady was there and she had this characteristic of laughing. She would laugh on every small thing and small thing. So that is a symptom of the medicine which is used for ALS. It produces that kind of effect on the patient. Many patients who have, so if you are very sure about some sign or symptom that okay, this is a characteristic in a patient. For example, if some patient comes who is not having ALS or who is not having that medicine and he shows this kind of symptom, that laughter which is inappropriate, the laughter, very small thing laugh makes him or her laugh, then we will say that this is a very characteristic point or very characteristic symptom, something which comes involuntarily, which is cannot be controlled by the patient. But if we know, that is why we also need to know what kind of effects, like side effects, some particular medicines can show, so that while taking the case we can understand what are the characteristics or what are the characteristics of the disease and what are the symptoms that are produced by the drugs or the medicines. But still, in some cases, if we are not able to understand that okay, whether this symptom belong to the medicine or to the original disease, it is better to take everything which we think of to be characteristic and base our medicine on it. And by thus tracing out the complete picture of the disease, he will be enabled to combat it with a suitable homeopathic remedy, so that the patient shall not fall a sacrifice to the injurious drugs he has swallowed. So he will find a suitable homeopathic remedy, a similimum, based upon the characteristics of the case, whether they belong to the drug, whether they belong to the original disease, if there is some confusion regarding it, and he will give the medicine so that at least the original disease, because in these kind of cases it is not that we will only see the symptoms of the drugs or the medicines. The original disease is also showing its symptoms. The characteristics of original diseases are always there. So at least when we will give a remedy according to that thing, the original disease will start decreasing and the patient will need less of these medicines, and we'll start telling them to taper down or stop with those kind of medicines. Okay, so we have to because the idea of the case taking is to individualize the case, to bring out the characteristics so that we can find a remedy according to those characteristic symptoms, which is similar to all those characteristic symptoms. So whenever we are doing the case taking, we are taking the case, we have to keep in mind that I am going to individualize the patient. I am going to understand how this patient is different. What are the different symptoms? Even we go to that preciseness of asking very small things. What kind of color or of the urine is there, what kind of sediments are there, what kind of taste is there, very small things, so that we can find characteristics of the case, and then we match those characteristics of the case with the characteristics of a remedy and we give that remedy. So we have done till aphorism 92. We will start with aphorism 93 next time. So I will request you that you go through these aphorisms once again during this week, because they're very important. Even if you are a practicing doctor, these things basically allow, these aphorisms allow you to make you to think about what is necessary and what I have to know, what I don't have to do, what is not required of me. I think every 6 months these aphorisms should be read. They should be read so that we can keep improving our this art. What I can see in the, what I can ask, what are the things where I have to focus. For example, those four qualities of being unprejudiced, sound senses, attentive observation, and fidelity, loyalty, truthfulness. If we don't read it, we will forget it. But reading it again and again, it makes inside, it is more of reminding of ourselves that what is required of me, because it is very important to remind so that it becomes, a part of you. Because there's, as a person, we all are physician is also a person. There are so many things which are happening in the life, or which have happened in the past. Most of us are prejudiced. Most of us, I will say almost all of us, are prejudiced regarding the things, regarding people, regarding the events. We see the things in a same way every day, but that should not reflect in our case taking. When you are taking a case, you should not be you, basically. That should not be reflecting in our case. That is a requisite. So when we go through these aphorisms, we remind ourselves again and again, no, I have to be unprejudiced. I have to be unprejudiced. Okay. So please go through these aphorisms once again. If you find any difficulty in understanding something, if you find something, which needs to be explained more, let me know about it. You can send the questions on the WhatsApp, and we will discuss it in more details. Okay. So with that, I will thank you all, and a very good night. Thank you.